Koto, welcome to this Department of Public Health, I want to say symposium, that's not quite right, is it? What's it called? Seminar, thank you. I think probably most of you know me. I'm Diana Safati. I'm the Head of Department of Public Health. And it's my great pleasure to introduce Dr. Jason Gurney, who works within the C3 research group. That's the Cancer and Chronic Conditions research group. He's co-director or associate director or something like that. This work is really important work. It relates to diabetes and in particular complications of diabetes. As we all know, the rates of diabetes in this country and in most developed countries are rapidly increasing. So this is an important health problem now and likely to get more so. So the title of today's presentation is A Limb Lost Every 30 Seconds, Diabetes and Lower Limb Amputation. Jason.
Thank you very much, Di. It's a pleasure to be here to speak to you all about diabetes. I came to the department having done my doctorate studies in the context of diabetes. So while most of my work here in the department has been around cancer, I've actually done, I come from quite a lot of postgraduate work around diabetes. So I'm quite passionate about somehow linking my work together. And that's why I've decided to talk about our work in diabetes today. I titled the talk, A Limb Lost Every 30 Seconds, Diabetes and Lower Limb Amputation. It's one of those kind of things that makes a nice title, but what does it actually mean? A limb lost every 30 seconds. It was estimated in a paper that was published a little while ago that a limb is lost every 30 seconds due to diabetes somewhere in the world. It's one of those, as James puts it, a meaningless statistic that doesn't actually mean anything. I think it was compared to landmines, I think, at that point, where a limb was lost every 30 minutes or something like that. But it does make a nice start to a title anyway, to draw the attention. So To kind of rifle through some of the initial slides, I think all of you in the room will understand very well, but I just want to make sure that we get ourselves on the same page. So what is diabetes mellitus? Well, diabetes is a metabolic disorder which is characterized by dysfunction in the way that our body deals with sugar. And at the heart of it is a problem with the hormone insulin, which I like to think of as the key that sort of unlocks the cell to let the sugar from our bloodstream go into our cells. In a person with type 1 diabetes, this dysfunction in the uptake of sugar is caused by an inability of the pancreas to make enough or any insulin at all. And in type 2 diabetes, our pancreas just can't produce enough insulin to keep up with demand, and our cells develop a resistance to that key. It's like the key doesn't fit really well anymore. And this results in a state of chronic hyperglycemia, or high levels of sugar in our circulating bloodstream. So this is, in effect, the what is diabetes slides, the basic start. As Di touched on before, diabetes is becoming more common. So this is data from the World Health Organization, which is looking at the prevalence of diabetes across countries. So this dashed line here is kind of the world average, and then it's broken down by income levels here. And what we see is that over time we have very much increasing prevalence of diabetes around the world, and also, troublingly, if we look at the low income line, is catching up very fast with the higher income countries as well. So that's sort of global data. This is from New Zealand. So this is data from the virtual diabetes register, which I'm going to talk a little bit more about later in the presentation. So this vertical axis here is just the number of New Zealanders who have diabetes. And this is just going back to 2010. So this is the increase from 2010 to 2016, where we had roughly 190,000 in 2010, broaching around 230,000 as of 2016. So when Di says this is an ever-increasing problem, this is absolutely true. And this increase over time, as most of us know, is largely driven by a substantial increase in the incidence of type 2 diabetes, which we also often refer to as lifestyle-related diabetes. And that, of course, is largely fed into by diet-related things around obesity as well. So this data here is from the US. This is the proportion of Americans who are obese. This is data going right back to 1999 and to 2014. The latest data is telling us that around 38% of Americans are obese. I think even more troubling, around 17% of American youth are obese. In terms of data from New Zealand, this is data from the New Zealand Health Survey Data Explorer. If no one's had a play with that, it's a really cool tool, which has only come out in the last year or so. And this tells us, it's a great way of visualizing New Zealand Health Survey data. And this is telling us that around about a third of New Zealanders are obese. It's not just overweight, that's obese. And of course, it's important to note that diabetes does not occur in isolation. So this is data from a paper that of ours that I'm going to talk a little bit later about. But this is the top 15 most prevalent chronic conditions among patients with diabetes living in New Zealand in the year 2010. This is from the VDR, the Virtual Diabetes Register. And this is data from hospitalisation data linked across to hospitalisation data. And this is the prevalence of the condition. Now, this is through hospital diagnoses. So a lot of these appear to be low prevalences, but that's because we're getting conditions at the more severe, or patients at the more severe end of the spectrum. And some of the more common conditions, metabolic disorder, that excludes hypoglycemia. So this is largely lipid-related disorders. Hypertension, a vast array of indicators of poor vascular health as well, which we'll get to a little bit more. So that's kind of the background to the disease that we're kind of facing in a nutshell. But what I want to talk to you about today is the work that I have done and others have been doing as well around lower limb amputation. And I think the easiest way to visualize the pathway from getting from a state of diabetes through to ulceration and ultimately amputation is this little thing that I drew from, it's a diagram straight from my PhD. It may be the only useful thing other than getting the PhD itself that came out of my PhD thesis, but we'll get to that, I promise you. So this is, if we think about a patient starting with a state of diabetes mellitus. Now, I'm already troubled by the direction of these arrows. This is 2010 Jason that was drawing this, so don't pay too much attention to directions of arrows. But this is the contributing factors going down towards ulceration. So we have, as sort of primary problems here, we have poor glucose control, so that's chronic hypoglycemia. We have poor vascular health as well. And then we have a condition that I really want to focus on talking about today, which is peripheral neuropathy. Peripheral neuropathy is more or less the first complication that arises out of diabetes, and it's essentially a dying back or a loss of function of peripheral nerves. And it happens in a distal to proximal way, so it happens from the extremities climbing back up. And that neuropathy, the way that neuropathy impacts a patient can kind of be broken down into these two separate areas. One, we have the autonomic areas where we have a reduction in sweating. And believe it or not, it's really important that our feet can sweat. It's not just annoying by getting sweaty, smelly socks. It's a really important function. It keeps our skin nice and supple and wet. If we are unable to sweat, we can have drying out of our skin, and that becomes really important. And I'll show you some photos later on, lucky you, of some gross feet that have very much dry skin and callousing happening. Then we have blood flow shunting as well, which reduces the nutrient supply to the periphery, which is really important, and ischemic foot, so not enough blood getting to the foot in the first place. Then coming over to those neuromuscular side of neuropathy, we have a reduction in pain and sensation. Funnily enough, a lot of patients experience a ramping up of pain. So in the early stages of neuropathy, patients might report having increased sensation in their feet and feeling these awful tingling pain, and they can't even have a sheet sitting on their foot. So when we say a reduction in pain, that's not necessarily a linear thing. It's usually sort of goes an increase in pain followed by an overall decrease. And that's really important because pain is our friend. When it comes to our health, pain is absolutely our friend. It tells us when something's not right. The best way of illustrating that is I had a patient in my PhD that 3 years prior to taking part in my study had been working on a job site and came home and went to take his boots off and couldn't take his boot off his foot because he had trod on a nail and the nail had attached itself to his foot. And so his boot was stuck on his foot, and he had no idea whatsoever because he had lost complete sensory function of his feet. And this is a patient who had severe type 1 diabetes and severe peripheral neuropathy. So that's a significant problem. Reduction in proprioception, so knowing where your joints are in space, is really important as well. Reduction in motor function, so motor dysfunction. Altered biomechanics, which I'll get back to. This is an area of particular interest for us. And this resulting in reduction in joint mobility, so just your ability to move, particularly your ankle joint. And an increase in the stiffness of your soft tissue. So when we're thinking about those calluses and having nice, soft, healthy feet, having an increase in the stiffness of your soft tissue is not good news. And all of these things kind of in combination with these external issues around having incorrect fitting footwear, knowing that you've got incorrect fitting footwear, because if you've got a loss of sensation, you might not even know if your shoes fit you properly. Lack of access to high quality foot care services, as well as just not having a decent access to foot care education as well. All of those things kind of feed in to an increased likelihood of a foot ulcer happening. And as we'll get to in a second, a foot ulcer is one of the kind of necessary factors in lower limb amputation. Not all lower limb amputation, but certainly most. This is just a little picture just to illustrate one of the things that kind of happens. This is clawing of the toe. So this is neuropathy. So this is where the muscles are atrophied, and we have this is one of the metatarsal heads here. So this metatarsal head is kind of pointing down as well as the phalangine pointing up. So what you have is this increased pressure happening when people are walking, as compared to on the right hand side here where you have a normal foot. So this clawing is definitely quite a problem. And we can kind of see that a little bit here. If you've ever seen someone's toe like that, they often call it hammer toe. That's generally one of the core signs of peripheral neuropathy. So we have what I was talking about before, the problem with skin flaking. So this is calluses under the first metatarsal head, third metatarsal head, and fifth metatarsal head. This patient also has clawing. They also have this thing called hallux valgus, which is where your big toe points in towards your other toes. That also increases the loading, especially under that first metatarsal head. And over time, as all of those factors that I covered in that diagram, as all of those factors kind of contribute to a breakdown of that tissue, and you end up, gross image to follow in case you're worried, you end up with an ulcer. So this is actually a very clean ulcer. This is from a colleague of mine who's a clinical podiatrist up in County Monaco. This is a very clean, recently cleaned ulcer, but as you can tell, if you can kind of think of that as a before and after. This isn't the same patient, but you can think of this as a before and after. We have severe callousing happening under the first metatarsal head, followed by ultimately an ulcer happening. And this is important because 80% of all lower limb amputations among patients with diabetes are preceded by a foot ulcer. So 4 out of every 5 amputations among patients with diabetes follow a foot ulcer. So there's 2 major types of amputation. This is kind of a broad grouping. You can more or less group things however you like. But in terms of our talk today, we're going to group those in terms of major or minor. So the major amputation is sort of through or above the ankle joint, and a minor amputation is anything from below the ankle joint. And that can include taking toes off. It can include transmetatarsal, where you basically cut a line straight across the metatarsal heads, and anywhere in between. There's no such thing as a quote unquote normal usual amputation. There's all sorts that sort of happen. There's some amputations that I've seen where patients have just lost their second toe as well as the second metatarsal head. So there's all sorts of different amputations that can happen there. So that kind of covers a little bit of the background around amputation. But how common is diabetic lower limb amputation, to get to a little bit of the data that we've been looking at? Well, more than half, it's important to say that more than half of all diabetic foot ulcers become infected. And around 1 in 5 of the foot infections that are moderate or severe result in some form of amputation. So we have a big problem here. And in the US, 4 out of every 5 lower limb amputations happen among patients with diabetes. So we're still we're currently looking at this in the New Zealand context, and also this is relatively historical data. This is from the early 2000s. I suspect that we'll find even more lower limb amputations that are performed in New Zealand are performed on patients with diabetes. So the data that I want to show you today is a study that we've just published, and a lot of the stuff is just very freshly published, which is cool to be able to present that. It's a study that we published looking at the risk of lower limb amputation in a national prevalent cohort of patients with diabetes. The methods of the study. So we took all patients who were on the virtual diabetes register from 2010. Virtual diabetes register is effectively a virtual register of patients who have diabetes. And it's designed to take data from multiple informant databases into one central location, and basically assigns a status of whether or not a patient or a person has diabetes. It's based on whether or not someone's had HbA1c tests, whether or not someone's on metformin or another similar drug, whether someone has a diagnosis in a hospital setting of diabetes, whether someone's been to an outpatient clinic for those sorts of things. It's a relatively complex algorithm they run through. It's not that complex, but it's relatively complex, that they run to assign whether or not a patient has diabetes. And it's not a perfect science, so they had a recent upgrade in the last year or so of the definition of what defines someone as having diabetes. So it's not absolutely a perfect database, but it's a great springboard to do this sort of study, because we have a general sense that the patients that are on this register are probably diabetic. And then those patients that we had defined, so everyone in New Zealand living with diabetes in the year 2010, we then followed them for 4 years using hospitalisation data, both private and public hospitalisation data, and looked for instances of major and minor amputation over a 4-year period. And then we used mortality data to censor patients who died during the study. So this is some of the data from the study. So over that period of time, we had around 800 major amputations, so that's above or through the ankle, and we had more than 1,200 patients who'd had minor amputations. In terms of sex, a really interesting phenomenon happens not only in New Zealand. This is consistent with international literature, where men are more likely to undergo lower limb amputation than women. So even after we adjust for sex, age, or obviously for sex, when we adjust for age, ethnicity, deprivation, rurality, comorbidity, and whether or not they had a prior amputation, men are about 40% more likely than women to undergo a major amputation, and around 80% more likely to undergo a minor amputation. In terms of age, there is a somewhat of a trend that the older you get, the more likely you are to have an amputation, but there's not a heck of a lot going on here, and this is more or less consistent with the underlying patient population. In terms of ethnicity, we also see something quite interesting here, where we have Māori patients around 65% more likely to undergo a major amputation. However, really not any more likely to undergo a minor amputation. So this data around major amputation is very much of interest, and we are going to be doing some more work to try and get to the bottom of what's happening here. That is not adjusted for ethnicity. No, that's right. So I was lazy, and so this thing along the bottom here adjusted for just means all other covariates. Yeah, exactly. So in terms of deprivation, so this is, instead of looking at the population who was the most deprived, we compared the patients who were the least deprived with those who were most deprived, and found that those who are least deprived, living in least deprived areas, are around 33% less likely to undergo a major amputation. That attenuates slightly when we go to minor amputation, but still somewhat different. And nothing really happening in terms of rurality. In terms of comorbidity, we used the Charlson Index for this one mainly because the timing of this paper was just before the M3 index, which I'll return to in a minute, was quite finished. Definitely saw a very, very strong relationship with comorbidity. So this is, if we compare patients who have the most severe level of comorbidity to those who have a comorbidity score or Charlson score of 0, we find that those who have a comorbidity score of more than 3 are more than 12 times more likely to undergo a major amputation, and almost 7 times more likely to undergo a minor amputation. Again, this is adjusted for essentially the kitchen sink. In terms of, when we were talking before about individual conditions that patients might be having, this is some of the sort of the top 5 conditions in terms of the relationship between the individual condition and the risk of major amputation. So the first one here is if a patient has peripheral vascular disease, not surprisingly, they're around 13 times more likely to undergo a major amputation. And of course, that's going to be a marker for vascular health in general as well, renal disease as well, and congestive heart failure, etc. So these individual conditions and whatever they represent certainly imparting a strong effect. Prior amputation is also one of the most important factors here. So I'm just going to focus on minor amputation here, and major amputation and minor amputation. But if a patient has a prior minor amputation, the likelihood of them having a subsequent major amputation is 10 times higher compared to those who don't have a prior minor amputation. And even if you have a prior minor amputation, your likelihood of having a subsequent minor amputation is more than 20-fold. So the conclusions of the study was that those who are particularly at risk were men, Indigenous Māori, and those who are residing in the most deprived areas. One of the conclusions that we made was that, and I haven't showed the data around death because I'm going to get to that in a second, death was common among the total cohort, but particularly among those who underwent amputation, with more than half of those who underwent a major amputation dying within 3 years of their procedure. And that was quite a startling observation. And so the next kind of natural thing for us to do was to look at that in more detail. So what we looked at is how common death was immediately after an amputation, and it's in a study that's just been published now. We looked over a much sort of wider period of time, 2005 to 2014, And we looked at all amputations that occurred over this time period, and we looked specifically at post-operative mortality, so death within 30 or 90 days. And what we found is that, so this is just the number of amputations that we found over that time period. What we found is, rather staggeringly, around 11% of patients who underwent a major amputation died within 30 days. And that went out to 18% over a 90-day period. If we look at minor amputation, it was only about 3%. So we're going to focus on major amputation for the rest of this. So this is again just broken down a little bit to get a little bit of a highlights reel of who's worse off here. There wasn't really a substantial difference between males and females. In terms of age, obvious difference. So those in the oldest age group, around 60% more likely to die than those aged 50 to 64. In terms of ethnicity, we found that Māori roughly 50% more likely to die following major amputation than the European other group. Acute admission, absolutely important in terms of risk of death. Comorbidity as well was surprisingly not as strongly associated as we thought it might be. So this is spine results. We were looking at literally the M3 score of 3 versus 0. We didn't find a very strong association, which we're still trying to explain. So the conclusions from that study was that we found 11% mortality within 30 days after a major amputation and 18% after 90 days, which is quite staggering. And being old and being Māori were the most important risk factors. Quite astonishingly, comorbidity wasn't consistently related. So how do we prevent amputation? Well, the first thing I wanted to start by talking about is the wrong way, i.e. my PhD thesis. No, it's so funny. It was so cathartic to come back several years after the fact and write some slides about my PhD thesis, because I think it's one of those traumatic moments in my life that I just didn't want to remember. And coming back again, I realized, yeah, it was really rubbish. I'm surprised they actually let me through. So it was amazingly written though, so that's why. So this is back, if we think back to our chart, if we think that ulceration is a necessary factor here in terms of ultimate risk of amputation, then we need to intervene somewhere on this pathway. And the idea behind my PhD thesis was to intervene particularly around the ulcer biomechanics part, particularly around increasing things like joint mobility and even potentially increasing sensation. My thesis was fancily titled "The Effect of an Exercise Intervention on Peripheral Sensory Motor Function in Neuropathic Diabetics." I wasn't entirely sure what that meant at the time, but it sounded pretty good. Now, the premise was that exercise might improve the function of injured peripheral nerves. This has been found in other contexts. And regular exercise, so putting someone on a treadmill or taking someone out for a run, weights training, is generally contraindicated in patients with neuropathy because of the increased risk of injury, especially around the repetitive or high loading of the feet. That's absolutely contraindicated in patients with neuropathy. So the idea was to do a low impact balance and strength training program. The idea was that would reduce the overloading on the feet, was low cardiovascular intensity. It wasn't going to put people under too much pressure. And it had the potential to improve lower limb sensory motor function and improve gross motor function in patients with neuropathic diabetes. That was the idea anyway. The premise was to deliver a 12-week low-impact exercise intervention to a really small group of around 10 neuropathic diabetics, and then to measure key outcomes before and after the intervention to see if there was any effect. So what I did was I measured twice before the intervention to see natural variability, and then again after the intervention, and then again as a follow-up. And just so you know, that was a terrible design. I wouldn't recommend doing it that way to pretty much anyone. However, I was naive. So in terms of the actual training program that we did, there was 3 components. One was this balance board exercise here. We had a whole bunch of different balance board exercises, isolated ankle strength exercises, and as well as just passive stretching exercises. And there were 2 sessions per week. They were roughly half an hour each, and it lasted for 12 weeks. And every 4 weeks, the intensity of the intervention sort of ramped up. I personally supervised every single training session at the home or business of the participant to make sure that the prescribed exercise equaled the received exercise. However, I really should have spent more time worrying about my inclusion criteria. So this was the people that I excluded from the study. I excluded people who had cardiovascular disease. So basically I excluded a massive chunk of my population, as we've already seen. I excluded people who had a currently or recently healed up foot ulcer. That kind of makes sense. I'll give myself a pass on that one. Pain while walking. I'm in my mid-30s and don't have diabetes, and I hurt when I walk sometimes. So that was a terrible idea. Rheumatism, for example, gout. that I can kind of get a pass away with that because gout can present sometimes as having similar symptoms to neuropathy, but so many patients with diabetes also have gout that I also cut out a chunk of the population. Partial or full amputation, I'll give myself a pass on. Severe lower limb injury or fracture, that barely happens anyway, so that was not an issue. Severe abnormalities of leg anatomy is a problem because lots of patients with diabetes have Charcot deformity, which is a deformity under the foot. So I was excluding them. And then recent significant reductions in vision when a lot of patients with diabetes have retinopathy. So I essentially walked into the study having a very, very select group of people to whom the results of the study might apply. Sounds like a normal clinical trial, actually. But anyway, I absolutely started off on the wrong foot in terms of the patients that I included in the study. Pregnancy, less of a problem. I then evaluated the impact of that exercise intervention on 6 different groups of outcomes. And when I say groups, it's because there was about 30 outcomes under each of these banners. The first one, sensory function, postural stability, gait, so walking, foot morphology, so basically the foot shape, plantar loading, which we're going to get to in a second around using a thing called pedobarography, ankle strength, so how strong the ankle was, and also patient-reported quality of life. So what did I find? Well, so sensory function I measured using a 20-piece Sims-Weinstein monofilaments. It's these little monofilaments that you tap on the bottom of someone's foot to see if they can feel it. And there's a little protocol that you go through to see how sensitive someone's foot is. Measured at 4 different foot regions, the hallux, the fifth toe, the third, metatarsal, midfoot. I found a very, very small improvement following the intervention, but really I could explain away that improvement by the people just getting better at doing the test. And there was no improvement in the patients who had the most severe sensory loss. So no thing there. In terms of postural stability, I came up with a marvelous model in terms of putting these little reflective dots all over people. We had a big motion capture system. I had 3-dimensional force plates sitting in the ground. Measured, I had different visual and surface conditions. I measured under multiple conditions, measured multiple variables around how stable someone was while they were standing. And there was no change following the intervention in anything that I measured. In terms of gait, I measured, again, I had this wonderful 3D model of exactly what I'd come up with in terms of looking at joint angles and moments and powers, the way that our joints are working. Looked at walking speed, cadence, etc. And you guessed it, didn't find anything. No significant changes observed after the intervention in any of them. The one that I really pinned a little bit of hope on was this foot morphology and plantar loading. So looking at pressures happening under the feet, using this pressure distribution platform, which I'll return to in a minute. So I looked at foot morphology, I looked at all these different plantar loading variables, and you can probably guess that I found nothing. No change whatsoever. Ankle strength, I thought, was a given. I mean, I worked with each of these patients over a 12-week period, and it was a staggered intervention, so it was over about an 18-month period, and I had worked these guys, basically they were working their ankle joints constantly during the exercise. And so I was so sure I was going to see something in terms of what was happening in terms of peak torque at the ankle, and I found nothing. Not a difference. In terms of quality of life, I measured it using the SF-36, measured multiple aspects of self-perceived quality of life, including physical functioning. And while I did find some perceptions of physical functioning had improved, especially among older patients in the group, there was no other changes in quality of life. So really, what did I find? Absolutely nothing. So this was 18 months of blood, sweat, and tears. And I just thought I'd share with you, I took a photo of myself just before I started the study, and I used to look like this, and somehow morphed into the dysmorphic person that you see before you. So I just want to spend the last little while, so that's kind of what not to do. I want to spend the last sort of 10 minutes, or 5 or 10 minutes, talking about pedobiography. Pedobiography is one of the potential things that we might be able to do about preventing ulceration. So if we remember that 80% or 4 out of 5 of every lower limb amputation is preceded by a foot ulcer. A primary intervention to prevent foot ulceration among diabetics is highly desirable for both the patient and healthcare services. So we're really operating down at this front here for pedobiography. This is what a pedobarograph looks like. This is the foot. This is the platform that you walk along, and essentially it measures pressures that are happening under the feet. And this is what it looks like if you have an insole-based system, which is the little insole sitting inside the shoe there, and that little thing on the side is what the patient carries along with them. And they can go walking for a long time, and you can either communicate via Bluetooth or you can download the SD card afterwards. And it collects data on something that looks like this. So it's essentially collecting how much pressure is happening under the feet. And there is some evidence that the use of pedobiography as a clinical tool can improve outcomes for high-risk patients. So the upshot of these slides here is that the idea is that if you take a measurement of the pressures that are happening under the feet, you might be able to design orthotics, for example, that are performing better for that patient and reducing load in better places for that patient rather than the standard one. And this is probably the best illustration of that, in which in an RCT, and quite a decent RCT, these authors assigned one group to receive standard orthotics and one group to receive orthotics that were designed following pedobiography. And 1 in every 4 patients who had the standard orthotic re-ulcerated, compared to only less than 10% of those who had pedobiography. So to design the orthotics. So there's definitely a value in that. Screening tool, I won't go into that. There's a lot of problems around it being used as a screening tool, which I have a lot of problems with it. So we were interested to know whether pedobiography could be useful in clinical settings in New Zealand. And so in late 2016, we conducted a pilot study in 3 separate hospitals in Auckland and Northland to investigate the acceptability and clinical usefulness of pedobiography in New Zealand. So we went to, this is at Counties Manukau District Health Board. This is at the Manukau Super Clinic, which is where they have a lot of the diabetic foot care services. So this is the platform here embedded in the ground. And we had a system set up to collect foot pressures under there. We also had a system here to collect the in-shoe pressures as well. This is my colleague Anthony, who's a really fantastic clinical podiatrist up there. And they referred patients over to us we wanted to know what they would find clinically useful from this tool. Also went up to whangarei, so we spent a lot of time in hallways, wherever we could find room. This is my colleague Dieter and also another colleague Uwe. I call them the Germans, who came over with a lot of kit to help us out with this. This is Steve York, who's another fantastic Māori podiatrist up in whangarei, who also works at Kawakawa, seeing a lot of the problems that I've been talking about today. And this is up in Kawakawa Hospital again in a hallway, and this is the platform here, and we also had the in-shoe system sitting just around here. We just asked clinicians to, wherever they found that something might be useful, whatever they thought might be useful, to come and bring the patient and tell us what they wanted to look at. And we documented all of the things, all of the reasons that they wanted to use the equipment for sort of future reference. So just by way of probably closing, I just wanted to show you a few of the different ways that the tool was quite useful, and some of the things that we might be taking forward in terms of potential practicality and usefulness of this tool. So the first one was around identifying patients who had a severe Charcot foot abnormality. So this top one here is the same patient. This is the left foot here, and the right foot here is a severe Charcot deformity in the middle, in the midfoot. This one in the middle here, under next to B, is a patient before one of the podiatrists came out and said, I've been doing clinical debridement, which is just taking the callus, the thick skin callus off the metatarsal heads to reduce loading. I've been doing this for 10 or 15 years, and I don't know if it actually works. Can we do a debridement of one of my patients before, have a measurement before a debridement and a measurement afterwards? And that's what the picture on the left here is, the pressures before the patient had that debridement, and the picture on the right is the patient after that had the debridement. So the debridement clearly is working in terms of reducing loading. Bottom one here is probably most interesting for me. So this is a patient who had severe loading. So this is kind of off the charts loading in the middle of their forefoot. And this is before they had an orthotic that was made with a custom designed orthotic with a puddle in the middle of it to soak up some of that force. And this is the before on the left, and on the right hand side is the after. So it's a way of kind of showing proof of concept that if we have an orthotic that is designed based on this information, that we can design a better orthotic that will actually reduce loading. So pedobiography is definitely one of the potential applications. And the next step is probably a randomized control trial, although we need to get funding and have time to do that. So watch this space. And that's me. Thank you very much.
Well, thank you, Jason, for that very wide-ranging presentation, from the national level epidemiology right through to that really clinical specifics. We have about, I'm going to say, 6 minutes for questions. We're going to have to finish a bit early because there's another presentation going on in the next door lecture theatre at 1 o'clock, which we need to go across to. So let's get straight into it. Richard.
Kia ora, Jason. That was a great talk, and I think your PhD may not have been successful in terms of generating outcomes, but it shows why you've developed into such a great researcher.
Thank you very much.
No, I got a couple of questions. One was in your sort of risk, when you were looking at risk factors and differences in occurrence of amputation. Pacific people had a much lower rate of major amputation. I think it's about 2.7. So I just wondered, is that something that ought to be explored? You know, why is it that here's a group with a very high prevalence of diabetes? I know it was fairly small numbers, it's 60 odd, I think, but nevertheless, you know, that looks like, well, what's happening that's, how is that happening that Pacific people have very low rates while Maori have higher rates? So that was one thing. And the second thing was, in none of your slides did you talk about my pet topic of smoking. And, you know, peripheral vascular disease is a huge part of this, and obviously the biggest risk factor for that is smoking. So I'm just wondering, you know, how much of a risk factor is that? How much of an opportunity for preventive work? You know, what's the attributable risk of smoking for amputation? You know, is that a better route to go down than
Probably. Definitely, actually. I'll answer the second one. You're absolutely definitely right. So I kind of didn't touch on the feeders towards poor vascular health, but tobacco is absolutely one of the most important. And I probably should have talked about that, but no, I absolutely agree. And pedobiography, I believe in it as an add-on, but it's not a fundamental prevention tool. It's not going to help us in the long run. It'll be useful in terms of preventing amputation or elongating the time to amputation for patients at the more severe end of the spectrum, but really it's an ambulance at the bottom of the cliff as opposed to at the top. So I do believe in it as a potential clinical tool, but I'm also very biased, so I need to temper that. In relation to your first question, I was also puzzled when I opened this data, having worked with the podiatrist in the clinic and seen so many Pacific patients when we were there. When I saw this national data, I had to double take and go back and sort of run the numbers again to make sure that it was right. Because I was quite puzzled. I guess we are suffering here from low numbers of people in general, as opposed to Māori and European, but there is definitely a high commonality of diabetes amongst Pacific people. So I don't know the answer to that, and I think we need to think about it a bit more. Any ideas would be great. I mean, the potential is for patients that may be going offshore, but I don't know, not being found. But it could be a data completeness issue.
Oh, sorry, Charlotte.
Dan, that was a great talk. I wanted to know, in your sort of failed trial of exercise well, actually not to prevent ulceration, but just to see whether exercise sort of worked in a mechanical sense, whether you thought that your failure to find an effect was because of your population, that they had a low risk of complications, although it doesn't seem quite right, whether it was the intervention that was not effective or that it was too small a sample size to find significant differences.
Unfortunately, I have to give you the standard answer, which is all three. It's absolutely all three. If I can prioritize them, if you like. Firstly, I think it was a study design issue. I think that the people that were in the study, for a start, I don't know what I would have done with the results, even if we found an effect, because it would have applied to such a small proportion of, I screened nearly 100 people to get those 10 that fit my little inclusion criteria. I mean, it was a ridiculous waste of work and time. So I think that I got that fundamental part wrong, which kind of led into everything else. I was really surprised that the fact that the intervention didn't increase ankle strength was really surprising to me, because that was literally what we were working on, which says to me that it just wasn't intensive enough. It wasn't doing enough. I was model coddling. I was too soft. I was too worried about doing damage, you know, this little PhD student, to cause some problem in these patients who are at such high risk of something going wrong, that I think I'm mollycoddled. That's mollycoddled. Thank you very much. So I would say that the intervention itself wasn't intense enough, and there have been subsequent studies that have shown they've been a little bit more brash and shown an impact of more rigorous exercise in terms of reducing risk of future ulceration. So I think I was just too soft. Yeah. Thanks, Charlotte.
This might unfortunately be the last.
Yeah, just really interesting, and I thought you were a really good presenter and nice to reflect on your doctorate. Just a couple of observations from mine. I've had a hip operation recently, and they basically, so I was particularly interested in the gait stuff. There's now a wait of 4 months to get into physio in the hospital here. So the issue about follow-up and the kind of physio, especially the rigorous physio, I think it's really important. And also, some years ago, we had a HRC project about the same time that Charlotte was looking at this issue, and we took lower limb amputations for diabetes and for people who'd had road traffic accidents and compared the kind of support they got in both cases. And of course, it was much more if you were your ankle was crushed by a motorbike, and just seeing the issue about orthopedic shoes and so forth. I mean, that's pretty important actually in terms of that. So, which we have that data was rather, if you ever want to have a look at it, because we didn't publish it.
Short answer is absolutely. And around the shoes thing, I mean, that is an absolute issue, and especially compliance to shoes. So a lot of the podiatrists talk about having, given these shoes that have, they have these little moon boot looking things that have interventions, and they're not the ones that are total cast that you can't take off, but the ones that you can take off. And they have no idea whether or not the patient's actually wearing them when they get home. If the patient knows how important it is to wear them, a lot of the podiatrists are European, and they're speaking to people who are from the islands that are absolutely second language, have no idea whether or not the information is getting through. So there's a real issue around compliance to intervention that needs to be looked at as well.
Great. Well, I'll bring the session to a close. I want to thank Jason very much. Jason, as you can see, he's got very broad-ranging interests. He's a very talented researcher, and he really cares about improving the health of New Zealanders. So I think that's reflected in the way he presents, and he's done a fantastic job. So thank you, Jason. Right now we have the presentation of the first contender for the new Pro Vice Chancellor for the Division of Health Sciences. For those of you who work at University of Otago, this is a really important opportunity to see who's going to be leading us forward. So I highly recommend for those of you who do work for the university that you move over to the Nordmeyer, sit through that. Thank you.